Hi, I'm Megan Block, and I'm going to present a case of hypercarbic respiratory failure. So, our case is a 66-year-old female with a past medical history of type 2 diabetes, hypertension, recent weight loss, presented after being found down and non responsive in her home. She was recently admitted for hypoxic respiratory failure just prior to getting a C6 to 7 left sided cervical phragmotomy for left hand weakness from cervical stenosis. Initial labs showed a normal CBC, CMP with a bicarb of over 40, UDS was negative, ABG with a pH of 7.18, PCO2 128, PO2 109, bicarb of 46, chest x-ray with ill-defined bibasilar opacities. For her exam, she had a shallow breast, decreased breast sounds bilaterally, but they were clear. A neuro exam showed obtended woman not verbally responding. She did open her eyes intermittently to stimulation. Pupils are equal and reactive to light, and she did move her limbs spontaneously. Her last neuro exam from prior hospitalization was unremarkable other than a 4 out of 5 grip strength on the left side. She was tried on BiPAP, but continued to have severe respiratory acidosis and required intubation, which did improve her acidosis and mentation. Unfortunately, when she was transitioned to pressure support, her end tidal CO2 increased to the 60s, and she was unable to be weaned from the vent and needed a tracheostomy. Extensive workup was done, as can be seen here, which was unrevealing, and eventually a nerve conduction study and an electromyographic or EMG study confirmed the diagnosis of ALS. So first, I want to go over the differential diagnosis of acute hypercarbic respiratory failure. It can help to think of it by mechanism, as shown in this chart. So if you're thinking that the patient's respiratory drive is decreased and the cause of it, then think of sleep apnea, stroke, overdose, encephalitis. If you're thinking about decreased respiratory function, then think of toxins, muscle disorders, spinal cord disorders, lower motor neuron disorders. If you're thinking of increased dead space is what is going on, then you would think of PE, COPD, or interstitial lung disease. And then the last main mechanism is simply increased CO2 production, which you can get with intense exercise, fever, sepsis, or steroid use. And in our patient, the mechanism was decreased respiratory function with a diagnosis of respiratory onset ALS. And ALS is a clinical diagnosis, but you can use diagnostic studies to help support the ALS diagnosis. And typically, a nerve conduction study and EMG study are done. And the electrodiagnostic criteria are complicated and can be seen here, but a neurologist will be the one ultimately interpreting the test. ALS diagnosis has shifted towards using the Gold Coast criteria, and that criteria is defined as progressive upper and lower motor neuron symptoms in one limb or body segment, or progressive lower motor neuron symptoms in two body segments. So one of those with the absence of electrophysiologic, neuroimaging, or pathological findings to explain symptoms. And ALS is thought to have many different variants, as can be seen here, and not all of them are listed. But the most typical presentation is limb onset, when symptoms first present as weakness and twitching in the arms or legs. And our patient was diagnosed under the respiratory onset variant. Only 3% of ALS cases are said to be respiratory onset, and 15% of those cases need to be emergently intubated, as our patient did. So big takeaway points are that although ALS typically presents with focal limb weakness, acute hypercarbic respiratory failure requiring ventilatory support is an uncommon presentation. We went over a framework for acute hypercarbic respiratory failure in thinking of it by mechanism, a careful history exam and basic labs, including CBC, CMP, chest x-ray, and ABG at a minimum are required in patients with acute hypercarbic respiratory failure. And lastly, ALS is a clinical diagnosis, but EMG and nerve conduction studies can help in supporting the diagnosis. Thank you.